So we are going to get started. Hi, everyone. It's Bunny Ellerin from Park Slope and the president and co-founder of New York City Health Business Leaders. So we put this slide up because this is really what the group was founded to do. And this has been a pretty difficult time during COVID on many levels. But one of the things that's really been sad is that we haven't been able to get together in person. And so we tried not to add to the noise too much and do a lot of, just redundant stuff. But we felt like it was time for us to try and get together and talk about issues that are relevant and maybe help ignite some conversations that help big ideas take shape among our members. So Anand, if you could move to the next slide. So we came up with this idea of a health business chat, and it's our first one. So it's a work in progress. And obviously Zoom is a work in progress too. It's not the easiest medium all the time because you can't really see people in real life. But anyhow, I just wanted to, say hopefully we will be able to do more of these. And we're excited that we have Gabby for the first one. So just sort of the rules of the game for today. We're on a chat, not a webinar. So in a webinar, you can't really see other people. We decided to go with a chat, like a meeting, so that people could see each other online. We are in the same vein, we are going to mute everyone while Gabby's speaking. And probably, then we'll have a discussion, but it would be good to stay on mute just in case there's any background noise. And obviously, we'd love everyone to turn video on, be cognizant of your backgrounds. So Gabby is going to present for the first 10 or 15 minutes about behavioral health and her area of expertise and what she's facing. And then I'll moderate the discussion going forward. What I'd ask is that you send some thoughts, questions, whatever, chat them so that I see them and we can start to pick from that. You can direct message me or put it in the regular chat, either is fine. And obviously once we get into the discussion, I just ask that everyone be respectful of time and place, no monologues or sales pitches, which is kind of the thing that, we don't like to do. And, because everybody kind of wants to participate, right? So that would be great. And yeah, okay, and the pro tip, while Gabby's speaking, there's something called the speaker view. I think in the upper right-hand corner, you might want to use that. And then when she's not speaking, if you want to see everybody, you can use a different view for full group discussions. If you're not exactly sure what that is, chat and Anand will help you. So, and thank you. I want to make sure to introduce Anand Gan, who makes everything happen seamlessly for the group. And very much so today. I have to say it's great to see names that I'm familiar with, some that I'm not. I've really missed seeing so many of you. And so with that, I want to introduce our speaker today, Dr. Gabby Farkas, who joined the group about, I think, 3 years ago. And struck me as a very innovative person to begin with. She's an MD, but who was always interested in the business of healthcare and has come to a number of our events, and we've gotten to know each other. I think she's a very smart, savvy businesswoman as well as clinician. And what topic is more interesting, or one of the topics that's most interesting today, is behavioral health, and particularly telehealth. So Gabby, I'm going to turn it over to you.
Thank you so much, Bunny. And Good afternoon, everyone. Very excited to be here. Thank you for the opportunity and to spend your lunch break with me. So let me share my screen. Bunny, you have to enable me to be able to share my screen.
Oh, wait.
I think.
Hold on. Let me see. Sorry, guys.
Same thing with the.
Oh, right, because we
Yeah.
hadn't. Okay, yeah.
Yeah.
Okay, sorry.
Okay. So I'm going to over here and.
Yeah.
Okay, so behavioral telehealth is our topic today. And again, I'm Dr. Gabriella Farkas. I am the medical director, as I call myself, of Pro Behavioral Health. And let me start by talking a little bit about myself and background and the practice itself. So I am an MD PhD. I graduated from Semmelweis University, Hungary in 2013. And then I came over to New York for a psychiatry residency at Northwell Health, which was back then Long Island Jewish Medical Center, where I graduated from in 2017. Started Pearl as a private practice in 2018 as a video psychiatry practice. So long before COVID, we were ahead of the curve. Hired my first nurse practitioner a couple weeks after and grew the practice to 7 clinicians at this point, a combination of prescribers and therapists. We have about 800 active clients, enrolled about almost 2,000 over the course of the past 2 years. And attrition is one of our issues, which I'm going to talk about in a little bit. But we have 800 active clients and an administrative staff of 4 people and billing services outsourced. So we do provide medication management, psychiatric medication management and psychotherapy. We provide about 80, I would say 98% of the appointments through video. So the video pretty much, the appointment looks pretty much exactly like this picture, which is from our website. Clients sitting at home on their couch, accessing the provider from pretty much any device. Our clientele is mostly adults, very typical outpatient practice, a lot of depression, anxiety, social anxiety, ADHD, insomnia, relationship issues, workplace issues, and basically the whole slew of outpatient psychiatry. I would say most of our clients are high functioning professionals of New York City, and the age group just happened to be in their 30s and 40s, most of them. Now, in terms of the payers, most of the clients come through commercial insurance, whichever plans reimburse for telemedicine. So we have some cash patients, but the overwhelming majority comes through insurance. Our volume, so we conducted a little over 6,600 appointments in 2019. Now, a little bit about behavioral telehealth in general. So this is a 30-year-old concept, and I'm a big believer of it. And I do believe that everyone who's involved benefits. So if you think about the patient's perspective, they basically have access to the exact same standards of care. It's not inferior to in-person. It's the same standard of care that's provided to their home in a highly convenient, discreet, time and cost-efficient manner. Our practice works around their schedule, so there's no need to, take time off or, lose productivity, sit in a waiting room, travel to appointments. We also provide same-day, next-day appointments, which we started with a collaboration with Castle Connolly, concierge medicine. But it's something that we're trying to extend to more and more clients and really be providing care in a time-efficient manner. From the provider's perspective, it's a very flexible schedule, freedom, work from anywhere, and basically a more efficient use of their time without the commute and without the inefficiencies of a brick and mortar setting. So it's pretty much boils down to being able to make more in less amount of time. So from the business perspective, there's less overhead because we don't have to maintain that whole brick and mortar operation. It's the same reimbursement. So whoever covers for tele, they have to cover the same rate as for in-person. There's an ease of hiring because of all the advantages to the providers that I talked about a second ago. We are fully paperless, and we're trying to automate our operations as much as possible. My folks know that my favorite word is workflow. So we write down everything, how we do it. We constantly try to improve and make our operations more and more efficient and more systematized, so it's less prone to human errors and omissions. Now, next slide. Okay, so the COVID-19 related psychological problems, and actually this is a slide that I created for Castle Connolly. We did a webinar early April, and I think since then, what's changed is that I don't have to even talk about this because we all went through all these psychological problems by now. So, you know, just briefly, if you think about health issues, contracting coronavirus, being sick, being in the hospital, friends, family members being sick, worrying about their health, especially older family members, our relationships suffering from either, you know, a lack of connection and social isolation, or feeling like we're stuck together and we can't get a break from each other. Work setting changes, right? So we're expected to maintain our productivity from home when kids are running around, spouses arguing about whose job is more important, right? Or on the other hand, a lot of people losing their job and facing financial issues. Business owners, the tremendous stress on business owners and trying to stay afloat during these times. Investments going the wrong way, you know, just financial constraints a lot of people are facing these days, and just an overall tremendous change in our lifestyle, right? So we're losing our routines, habits, places, people, and we kind of all have this sense of, oh my God, the world is never going to be the same. Now, more specifically to psychiatry. So we, in our practice, see a lot of first episode, which means never before experienced anxiety, depression, insomnia, adjustment disorder, even suicidal thoughts, hopelessness, new onset substance use. So people start spiraling into psychiatric issues that they've never experienced before. And on the other hand, whoever had a psychiatric condition even before, they're experiencing flare-ups, and more severe flare-ups than before, with new, more severe symptoms. They're relapsing to substance use just honestly out of boredom. I had a bunch of patients who like been sober, clean for so long, and they're like, you know, I was just so bored this past week and I did it again. There's a difficulty using coping skills and tried and true strategies for mental health conditions. So someone with a significant mental health problem, you know, talking about depression, bipolar, that's a recurring psychiatric issue, they pretty much spend their lives trying to figure strategies around how to manage these symptoms. And these strategies are breaking down right now. If you just think about, I have a lot of clients in the city who in the past few weeks were not able to leave their home because even the hallway, even the staircase, even the street is just too crowded. They were too anxious. They have a medical problem. They just couldn't leave the home, right? And exercise and spending time outdoor is a huge component in managing our mental health. So these all contributed to more severe presentation of existing mental health conditions. And then not to mention about hiccups in treatment, right? So, I mean, you name it, and there's an issue in that component of the mental health system. So if you think about doctor's offices closing, scrambling to convert to video, the provider is not available, out sick, traveling, just, you know, not in the office, patients are not available. They are fleeing New York, traveled out of state, harder to, know where they're at and how to get a hold of them. Interruption in access to medications, right? Avoidance of pharmacies. And a quick shout out to Capsule. I know they're probably on the call. We were trying to promote home delivery services to as many people as possible to minimize that unnecessary risk of going to the pharmacy. Our treatment plans are failing, right? So many times, we had the plan of stopping a medication, decreasing the dose, and we just said, okay, not this time. Let's just survive this period and we'll worry about everything else later. Interruption of established services, right? So patients are avoiding the ERs at all costs, because they don't want to get sick, obviously. So they're waiting until the condition gets worse, and then they need a high level of care, and it's more suffering and it's more costs associated. Entire outpatient treatment programs, partial hospital programs, especially for the severely mentally ill population, all the services established, the day programs, the residential housing, the oversight that their team, their ACT team, AOT team has been able to provide, all of a sudden there was a lot of interruption, less oversight. I've seen patients in the hospital who came in very ill because they mixed up the medicine, there were no oversight, they just became non-compliant. You know, people who need a lot of supervision in mental illness had a significant breakdown in their established services. If you think about entire units being closed, right? So in my hospital, which one is the unit that's going to be converted to coronavirus first? It's the psychiatric inpatient unit. So we're sitting in the emergency room, someone would need an inpatient admission and there's just not a bed to admit them to. And then not to mention the COVID outbreaks in facilities, which has been a huge problem. Now, ironically, COVID-19 also presented us with the opportunity for our Dream Business Operations. Why? Well, because with the announcement of national emergency, all of a sudden, all of those rules and regulations that are arbitrary from a clinical perspective and don't really make a whole lot of sense clinically, we didn't have to deal with those, right? So the licensure rules got relaxed because in telemedicine, you have to be licensed in the state where the patient is located at the time of the appointment. Right now, a lot of people are all over the place and we were just able to see them fine and provide that continuity of care that they so needed. We even had same-day licensing. So if we needed a new license for someone, it came back the same day, which is usually a 4 to 5 months process. Ryan Hyde Act got dropped. So all of a sudden we didn't have to see anyone in person because sometimes we do for certain prescriptions, but right now it didn't apply. We could just send in any prescription to any pharmacy, to any state, and again, provide that much needed continuity of care for the patient. Scheduling improved, so we didn't have to work so much around the patient schedule and provide all those off-hour appointments that we usually have to do. We usually do a lot of early mornings, late evenings, and weekends. But right now, everyone is just available anytime because they're home, right? So we are still able to see them confidentially and in a private way without doing a lot of off hours. And the insurance plans have to start paying for tele. So even the ones that were not paying before, and some even started waiving the copays, which basically mean the care, made the care obviously more affordable for the client. So I would say there, the national emergency provided more progress for telemedicine in about 10 days, even 10 hours maybe, than the last 10 or 20 years combined. Now, is this a once in a lifetime opportunity for us, right? So a huge uptick in new patient inquiries, I would say like a 40-45% uptick in new patient inquiries. Previously lost clients came back. So the attrition rate that I spoke about before, which comes from a variety of factors, but it's just higher than we would like it to be. All of a sudden improved because a lot of clients came back. New providers, all of a sudden everyone wants to do tele, and even the ones who didn't like it so much before left our practice, got terminated, they were all trying to inquire about the possibility of coming back and work with us. Colleagues started coming for advice. The first couple of days when everyone was converting to video out of necessity, my phone was going off the hook with colleagues calling for advice. How do I do this? Which platform to use and all that. And it actually provided us with a new business opportunity where we started an MSO company and trying to help doctors convert their practices to video and stay video. On the other hand, COVID-19, are we losing our edge, right? All of a sudden, everyone is doing tele and we're no longer new or different. So here are the big competitors that existed even before coronavirus, but at this point, some of them only do psychotherapy, though not medication management, so not the whole slew of mental health services. But right now, not only the big guys, even any private doctor's office is a competitor because they provide the same convenient video care. So the questions for the discussion would be, how do we become the go-to platform for all who like it? The providers who like it, the patients like it. Not everyone likes video, but more and more people do, and some people would never go back to in-person. How do we become the go-to for those people? How do we continue to differentiate ourselves? And is now the time to sell or merge? We have a couple of interesting opportunities lurking, or do we keep going and keep building the practice? So with this, I'm gonna turn it back over to Bunny.
All right.
Thank you for your attention.
No, this is so, you know, Gabby, I have a question. How did you, I mean, you've been in practice for a few years. What made you go to telehealth in the first place? I mean, because it seems like there's been a lot of resistance from behavioral health providers generally to do that.
Yes, I would say it was a business consideration. With the less overhead and the more seamless operations, it's just a cleaner business model. So that was the reason why I started as a telepractice in 2018. I just like the idea of it being convenient. There's so many things that are cumbersome. Just if you think about, I mean, every time I go to a doctor's office and I get that dreadful clipboard with those million papers that I have, I just like, I feel my blood pressure going up. Like this is done so much easier. And this is what we did, fully paperless. You get an email, you follow the link, you sign electronically, you fill out your information, and it's just, I just think it's so much better. And with our typical clientele, which is the 30, 40-year-old professionals of the city, they would never go back to a traditional office, I'll tell you that. And one of them even said once, and I thought this could be our tagline for the business, this is crazy convenient. You know, it's just so easy, so much better, so much more preferred. Yeah, so.
I like it. Crazy convenient.
Crazy convenient, right.
What about, and I'm going to get to the question others in a sec, but what about some of your peers? What are you hearing from them in terms of, yes, this is going to stay and it's the new wave, or I want to get back to seeing people one-on-one in an office?
Very, very mixed. Very mixed.
Interesting.
Some providers would never go back to in-person, and some of them can't wait, right? So it varies from, okay, I'm never renewing my lease again, to when is this over? And all I see, one of my comments, one of my colleagues commented on Facebook in one of the groups, all I see is nostrils all day. And I'm like, what are you talking about? I haven't noticed that in 2 years, you know, like, the interesting thing from the provider's perspective is that the video setting is a little bit more tiring. So you don't have the whole room, you don't have the entire body language. There's less source for the same amount of information you're trying to gather. So it's a little bit more tiring, and the end of the day, you feel a little more wiped out. And it's just the strain that a lot of, some of the colleagues don't want to deal with.
Okay, I just unmuted Jessica Pan, and actually if people can turn on their, I know that it'd be great if you turn your video on just so we can see you. But in any event, Jessica, do you want to ask your question?
Sure. My question is about
actually, wait, first, Jess, I'm sorry. Tell us who you are, a little, where you work, just so we have a sense of who you are and where you're coming from.
Sure. I am a mailman graduate. So I graduated from the School of Public Health from Columbia. And I found out about this group through the Columbia Health Business Conference that happens every year. And now I'm working as a clinical research coordinator at the hospital, at Columbia's hospital.
Okay.
And so I've always been interested in mental health, and now with it going into the telemedicine pathway. And my question is about patient confidentiality and how these type of interventions where patients may not be in a safe environment, how do you ensure that you can still have a confidential and safe conversation with them? And is there any work around like domestic violence patients who may need this type of service as well?
Yes, that's a great question. So when we enroll someone to the practice, we very carefully inform them about how this is going to work and how they need a confidential space, 45 minutes for the intake, 15 minutes for the follow-up sessions, depending on which service, a little bit longer, and no one overhearing them, right? So, I mean, it's something we can only control so much because obviously they don't come to our office, but what we do every single time, and as I said, it's the same standard of care. So every single time we start a video, we verify the location, right? So it can be something the patient gives us, an address. We also use a telemedicine platform that, based on the IP address, tells us at least the state where the patient's in, so we can make sure that it's a state where we're licensed and it's not going to be an issue. We are equipped to handle emergencies. Just, like if the patient was in my office, I'm able to call 911 and direct them to, and we know exactly, to room number basically, or to, the apartment number where the patient is located. So if there's a clinical emergency situation, which we have, from time to time, we are supposed to be able to act and direct EMS to their door so that they can be escorted to an emergency room. Now, if someone does not have the confidential space, it's a problem, we get a HIPAA form for whoever is going to be overhearing them. It's pretty rare, but some people live in an arrangement where there's a roommate, or most of the time they're able to make it work and ask the roommate to leave, or, the family to just go on a walk or whatever during the appointment. I have to say, I personally have not encountered a domestic violence situation, but it's a great question, right? Like, how do you help that person speak up when they don't have the privacy? Again, it's not something I encountered in the past couple of weeks, but it's definitely something that is a problem that we're supposed to be able to help with, right? And what I would say though, if any of our clients are in any kind of situation like that, they have a variety of ways to contact us, and not just video. We are available through email, secure messaging through the EMR, text. They can even chat with us instead of doing the video. So if someone is in danger, they have a variety of channels to reach us and let us know about it. So I think, there should be a way for them to let us know that they're in an unsafe situation. Again, it's not something I personally encountered during
Okay, let's refer well. What's your first name? Oh, I need to unmute you.
It's Vitas Casilius, Bunny. How are you?
Vitas, hey, how you doing?
Good. How are you?
HBS on the house.
So I had a question, Gabby, about your network. So I'm with a company called ReferWell, and we do a virtual integration of a care network. So we handle the transition from a primary to a specialist and so forth. And so we work for health plans. They're all struggling, as you know, to find enough behavioral health specialists. Mm-hmm. And we offer televideo, or we integrate to your televideo. But the thing is, do you contract with the plans directly, or are you just saying, I'm out of network, if you have a commercial plan, I'll send the claim in to them?
We contract, yes. And before the pandemic, we only were in network with select plans because some of them don't pay for tele. So right. A patient can have the mental health benefits, but not the tele benefits.
Right.
And all of a sudden it didn't work with us. And even within the same plan, you can literally have two people from the same company on a similar looking health plan. And we have to call individually for every single person. And one of them will have the tele benefits and the other won't have it. So it's just one of those things, that don't necessarily make a whole lot of sense. But this is one of the reasons why, one of the points in our business that we were not able to automate, because if we were a traditional mental health office, we would be able to check benefits online and take out that person-to-person phone call that's just, such a headache every day to do for every single new patient, but we just have to do it because of the telemedicine. But this is one of the issues we've been struggling with, is that we know that there's a tremendous need for what we do. And we are all, set up for the whole thing. We've been doing this just business as usual in the last 2 years. And we enroll about 40 clients maybe a week, but I think it could be much higher. That number could be much higher. And Sure. We've been trying to call these plans to let them know, hey, we're here, we're all set up, send everyone to us, we're ready. And it's just, I don't know where the leverage is, how to talk to the right person in that plan. So we are just not one in a million provider. It's not a million because there's very few psychiatric providers, but we're just not one of them. But, to let them know that we are here with the full-on video operations.
Got it. And
So
you
if
expect
you
the
have any ideas, that would be great.
Sorry, you expect the televideo payments to stay the way they're working now after the pandemic and the emergency is over? So you'll be able to practice across state lines even, right?
I really hope so, but it's hard to tell. I don't think anyone knows at this point to what extent we're gonna go back to doing things the old way. I'm pretty sure we're never gonna go back to being tele being that restrictive, but to specifically, you know, what is going to be, you know, continue to be paid for and what regulation is gonna go away, it's just hard to tell at this point. I would love for this, not the pandemic itself, but everything else to stay as it is right now. Because honestly, there's no reason for these regulations. And if you think about the VA, they are exempt from most of this, and they have the, you know, just the national tele licensure. Why can't we have the same? It really should be something we have access to, because there's such a shortage in behavioral health, and these issues are so prevalent. So much lost productivity, so much suffering. There's just no reason for all these restrictions to make it so hard, you know?
I agree. Well, thank you very much. Thanks, Benny.
I was on mute because my 16-year-old son had to tell me something. Anyhow, the beauty of working from home,
yes,
and making sure he actually does any schoolwork, hopefully. All right, the next one is about an EMR, and I'm Ryanra?
Sorry, my name here is Nisha Bala. I apologize for that.
I'm sorry?
My name is Nisha Bala.
Oh, Nisha, okay, great.
Also HBS 2012, nice to see you guys.
Oh, wow, HBS in the house. Okay, so what do you do?
Sure. So my background, I work actually at an MSO where we roll up ophthalmology practices. So a little bit different than you know, obviously psychiatry, but same sort of concept. We are looking to do more telehealth as well within ophthalmology. We don't see an end to what's happening here. We see sort of waves and ongoing waves, and the first wave of this really hit us hard. So we're looking to make sure that we're prepared for the next time that this happens. You know, I think one of the things, you know, we're interested in, obviously we have an EMR platform that we use, but would love to hear a little bit more, Doctor, about, you know, which EMR platforms you're using and how did you decide on that, or which video platforms? Because that, I think, does play into a differentiating factor in terms of how your patients engage with you. So I want to make sure that, you know, I understand that from your perspective.
Right, and let me just tell you, and you know this, but to the others, maybe it's an interesting thought, is that psychiatry is so much more disruptible than ophthalmology or a lot of other medical specialties, right? Because we don't lay hands on the patient. We don't do any medical exams. And it's just so easy to convert it to video right away, as opposed to other specialties where you actually need to, you know, have that physical intervention on the patient. So I know it's much harder for you guys. So in terms of the platform, it's an interesting question because there's so many platforms out there, and we work with a behavioral health EMR. It's called Valent. It's a specific psychiatric EMR, which I don't particularly like, but the one thing it does really well, and the reason why we keep sticking to them, is documentation, which is much longer in mental health than other specialties. So it's a good like 7-8 page document when we enroll a client, and every single follow-up is still a 2 to 3 page document, as opposed to some of the surgical specialties or other specialties where it's just really concise and a couple lines and that's it. So the one thing that it does is that it makes documentation very easy for the providers, and I wanted to make it easy for them so they like working with us and they stay. What it does is that we basically put half of the work on the client. So when we enroll them, as I talked about the physical clipboard that we don't have, thank God, but we have a couple of pages of electronic forms that they have to fill out, and we threaten them to reschedule the appointment if it's not done. They have to fill out those forms, and what the EMR is able to do is that it pulls those forms, and off of the checklist and all the information the patient puts in, creates a narrative off of that into my note. So even if before I touch that intake note, it's about good 4-page document. And it basically asks about all the factual information that I would spend so much time on during my appointment that I don't want to spend time on, because I want to spend time on verifying that information and building my report and coming up with a therapeutic alliance and a treatment plan along with the patient that we're going to be able to execute, right? So if you think about developmental history, pregnancy history, social history, even psychiatric history, have you been in treatment before, what medications you tried, what is your income, what is your family status, all these things, I can then take that note, take a good look at it, and all of a sudden get a really good sense of who this person is sitting on the other end of the video. And again, even symptom checklist, it sends it out to the patient. And so I look at it like a minute before the appointment, literally, and I know, okay, this is a moderately severe depression I'm gonna see here with some anxiety, insomnia, some alcohol use from a, you know, software developer who has a kid and who's married and lives in Midtown. You know, like what, so I have a really good sense of who that person is going to be, and all of a sudden I'm halfway into my appointment, right? So with this, setup, we were able to shorten the appointments a little bit, make them shorter, enroll more clients, make the provider's time more efficient, and all that, and take insurance, which is really rare in behavioral health, and make the care more affordable. In terms of the video, it's a separate platform. It should be built in. It would be much better if it was built in, but it's just so happened that it's separate for us. We use Doxy, which is honestly free, works pretty well, HIPAA compliant, everything you need, works on any device.
Yeah. What's it called again? What's it called?
Doxy.me, DOXY.
Okay.
.me. There are a bunch of them, but this is one of the free ones that honestly is pretty easy and very few technical difficulties. And recently they started doing this that I just said, that they show us the patient's location based on the IP address, which is very useful. Now, the fact that it's a separate platform creates some hiccups because the patient is trying to log into the EMR portal to access the video, and then it takes a couple appointments for them to realize, okay, no, the video is a completely separate link. I don't need to log into my portal. That's a separate login for different things. The video is a standalone application, right? So I would say that what we ended up, what ended up happening, which was never intentional, is that this whole setup that we have screens out the severely mentally ill because they're just not able to follow all these instructions and find the email, follow the link, figure the video, figure the portal, fill out the questionnaires. It's just not something someone with schizophrenia or severe bipolar is going to be able to do. So clinically, we ended up with a lighter, easier to manage population. And that's why I hired nurse practitioners, because I figured they're perfectly well managed by a nurse practitioner. The other big piece of that was that Medicare and Medicaid, before the pandemic, didn't reimburse for in-home services. So we just were not able to work with their clients. But I would love to diversify the practice clinically, from the clinical perspective.
Thank you. That's helpful. One quick follow-up question. Are you reimbursed the same for nurse practitioners as you are for psychiatrists, or
No.
It's a different reimbursement structure?
Usually, Cigna is the only one that reimburses the same. Unfortunately, all the other ones reimburse less.
Okay.
And that's one of the issues that we have, is that nurse practitioners these days almost require the same salary as a doctor, because they know their value. Behavioral health has an incredible shortage of providers, and they get very aggressive in their negotiation, but the rates are lower that you get for their services. So that's one of the headaches that I go to bed with almost every day.
Yeah, I can imagine.
Okay. All right. So next we have Julie Colzett.
I
unmuted you.
Okay, great. So I have a couple questions. Is there any place you would like me to start?
Well, first of all, what do you do?
Sure. So I'm a cognitive behavioral therapist. I have a private practice in Manhattan. I also have done some work in the digital health consulting space. So I would love to learn more about what assessment forms you use for patients. Number one, also, are you tracking treatment progress? Also curious about the integration of wearables in your practice. And we know that all that data is very helpful to us. So especially in the behavioral health world. So if you would speak to any of those, that would be much appreciated.
Yeah, I'm gonna try not to go into the too much the nitty gritty because I can talk to you maybe offline.
Sure.
But it's so Valent has about 50 built-in behavioral health questionnaires, which are the ones that we use. Upon intake, it's a clinical history form and a symptom screener, along with the depression scale, the PHQ-9, the anxiety scale, GAD-7, substance abuse scales. So, you know, OCD scales, ADHD scales. So basically a target symptom specific, validated mental health rating scales. We also work with the American Psychiatric Association on creating new scales. So yes, we do track progress and they pull data off of the back end of our EMR. Wearables are not integrated. Unfortunately, it would be really cool. What we do, honestly, if I have someone on a stimulant, I'm gonna make them buy one of those blood pressure cuffs that you put on your wrist, 20 bucks on Amazon, and I tell everyone it's just worth it. And they pretty much do it every time I'm on the video with them and we check their blood pressure. But it would be really cool to make that a little more, you know, like a higher tech kind of integrated data set. It's just not something the EMR does, and we haven't had the capacity to figure out how to do it. And because our clients are pretty young, very few medical problems. Honestly, frequently I am the primary care provider because they just don't have a doctor. They don't care. They're healthy. They're young, you know? So it's not something that has been a priority so far. They're pretty health conscious, you know, they're overall in pretty good shape physically.
So Gabby, I have a question. And obviously people can connect offline on certain things, but all right, so you're at a pivotal place, right? I'm not going to ask you any specifics around revenue or, you know, who's lurking, but we do know in the news, I mean, we've seen, at least in some industry news, that there are potentially some big acquisitions that are going to happen with some behavioral health telehealth companies. So when, you know, can you talk a little bit about what you're facing now? I mean, you've been approached by buyers. How are you thinking about it?
Right. So even before the pandemic, we started getting these inquiries, but we got several during the past few weeks, and we have some pretty advanced discussions with particularly one of them. So a little bit of a different opportunity. One of them would be for, so basically both of, two major ones. Both of those would buy all the assets of the company. So basically providers, patients, you know, credentialing, everything. And then have, keep us on board for patient care, keep me on board specifically for either a CMO or kind of a medical director position where I basically continue doing what I've done for someone else as an employee, right? And I think a lot of us on the call understand the dilemma of going from the freedom, but also all the stress of being a business owner to being able to put it down at 6 p.m., forget about it, and just take a salary, but lose the freedom, the creativity, the autonomy, the independence that, you know, we so enjoy, and that's why we went into this this space, right? So yes, this is the biggest dilemma, I think, because there's going to be a lot of consolidation in the space. So I think anytime in the next 5 years, if I wanted to sell the practice, I don't think it would be difficult to do. And it's not even about the numbers, because, you know, like, let's face it, you can make money a lot of different ways, you know, but it's pretty much, okay, is this the right time strategically for the practice to get to the next level? With 800 patients, 7 providers, I'm realizing I am becoming the limitation of this practice, because I am trying to be everything for everyone, right? Everyone comes to me. I only have 24 hours. I'm trying to, you know, not work 24/7. So is getting to the next level, is it through a merger, through an acquisition, or is it trying to find investors, creating a board of a CEO or CMO, or, you know, like an advisory board, and trying to become a full-on, you know, corporation, or you know, like what is basically the way to get us to the next level.
Do we have any folks who have gone through a sale, or at least the way to think about it? Maybe not. Okay, well, let's.
Well, hey, this is Gurnik, actually. So I can't speak to a sale, but I can speak to the other side of this, which to continue to grow your business organically and ways in which you might entertain doing such things. Because I've been a part of and witnessed the growth of practices from single provider to multi-provider and building out more of an established business framework. So I'm kind of curious, can you talk us through a little bit about the business structure? So, you know, any human resources and assets that you're currently employing to give structure to all of the clinical work that you're doing.
And Gurnik, well, thanks for piping in. So why don't you just say where you're from, you know, where you're from?
Yeah, sure. So I'm currently the product manager at Cognito. We build clinical training and education solutions in healthcare, but I actually come from a long line of entrepreneurship as well, focused on healthcare and growing and developing businesses. So I usually come in at these sort of pivotal points in a lot of practices, but also digital businesses, agency businesses focused on healthcare, trying to go from something that is sort of individual practice or provider into a much larger scale operation.
Right. And I mean, so if I'm understanding the question, so basically we are a PLLC. We contract with clinical providers. So I'm the one hiring, firing, mostly hiring, luckily. So we screen a client, screen a provider, you know, we see if it's a good fit. We start employing them and then start filling them with a caseload. Credentialing has been outsourced. Now I'm trying to take it back to internally to credential them with the insurance companies. Some of them are already credentialed when they come to us. And basically supervising nurse practitioners as much as needed. I try to hire the ones that are already independent and don't need a lot of supervision. Same with therapists. So in terms of, we don't have a human resources department, you know, it's pretty much, I guess, one of the things that I do. I tried to promote one of my nurse practitioners to an assistant medical director position once, and it just didn't end up happening. And this is one of the things I realized, is that no one is going to be as invested in this as I am. And everyone is trying to have their time off when they're done at the end of the day. So yes, I guess this transition from, you know, being a business owner, doing everything myself, to, okay, how do we allocate those tasks so I have the right people at the right places, right positions, and I can sort of forget about, or I don't have to be everything for everyone, right?
Yeah, absolutely. So you're basically one FTE that's responsible for the business management overall.
Yes.
And then a couple of key functions are outsourced.
Yes, billing and credentialing. Yeah.
Right. So yeah, I've seen a lot of practices be really successful by hiring into those business positions, starting off with you know, case management and folks who are involved in overseeing the reimbursement and the human resources component. So you basically have 3 additional FTEs that come in and handle the primary clinical practice components, and then you can expand your provider networks in that way and allow you to budget additional resources for things like marketing, technology enhancements, and grow the team that way. So, you know, what I've seen people doing from sort of one business practitioner with a couple of clinicians underneath, you know, they'll go out and they'll either find an investment partner who can help assign and hire those FTEs, or perhaps they've been able to budget and plan for those additional incorporations through planned expansions of patients and resources, which it seems like you're in an opportune position right now with you know, foreseeable increased demand. So there's, I think, a really nice pathway for you to grow this organically for the next 6 to 12 months, taking full advantage of the increased demand and get yourself into a much better position to potentially sell on the back end of that as well.
Makes sense. Thank you. I took note.
Thank you, Gurnik.
Yeah, you're welcome.
And Nisha is back, and she can speak to the purchase side of practices.
Sure. Yeah, no, I like what Gurna is saying. One other thing to consider here as well is that you know, obviously you can hire an FTE, but you can also just outsource to a vendor until you get big enough that you would actually need a full-time employee, especially for billing, credentialing, marketing. Finding the right people is probably the hardest thing to do, but once you do, I think it takes a lot of the work off of your plate. So I'm sorry I got kicked off. I don't know where you guys were in the conversation, but you know, some of the things that you really want to make sure that you're ironing out, and probably having a really good lawyer, a transaction lawyer who understands how to do this is super important for the negotiation. We see a lot of our medical practices and ophthalmologists who will come in and they're using their real estate lawyer or maybe their accountant to do the transaction negotiation, and it never bodes well for them, and it makes the whole process longer, and nobody really maximizes value in that situation. So I think that's really, really key. But one of the things, you know, I think that all of our doctors, everyone that we work with from a medical practice perspective, you know, what's really important is making sure you're getting and maximizing the multiple and minimizing the earnout that you would have to have in your contract. So getting cash up front is sort of king, because basically what happens is once you sign that paper, there's a lot of things that you don't have control over anymore, right? And you can try to document everything, but you know, through the process, it can become a little bit hairy. So again, trying to get as much as you can up front and get that in your pocket. One thing, and in conjunction with that, anything that you want, make sure it's in writing, either in the contract, an amendment, an addendum, because I will, you know, I'm speaking from sort of the private equity and the MSO side. There's a lot of things that people will say, but a year down the road, it's maybe in an email or it's not honored. And if it's important to you, it really needs to be documented. The other thing, just to call out here, a lot of our physicians don't realize how much control they give up. So things like very simple things sometimes, like marketing, branding, logos, colors. People get really, you know, sort of upset about. They say, well, I don't like this or I don't like that. And you know, once you sign over your practice, you don't really have that control anymore. So you want to be really careful about that and make sure you understand what's important to you. And then the other, you know, the last thing I'll call out, because I think this is important and it's sort of unprecedented right now, with what's happening with COVID. What we're seeing and actually doing, and it's not just us, it's a lot of different companies, hospitals, everyone's renegotiating contracts. And this is renegotiating of contracts in midterm, right? And so you have a 5-year contract, you should be paid as a salaried employee, but because of COVID, you know, the cash flow is not there, and all of a sudden you're looking at a completely different, you know, salary scenario. Just be aware of that, because again, I don't think that would have really ever been the case before. But we have had to do that with a lot of our doctors, and we're trying to do it in a partnership fashion, but it's not an easy pill to swallow when you think you're signing on for X and all of a sudden, you know, you're being paid 20% of that for a period of the shutdown. And therefore, you know, you are not making what you thought you were making. And then trying to bring that to court is actually really difficult, especially during this time. So just wanted to call that out, because I don't think anyone really talks about that too much.
Thank you. That's very helpful. Thank you, Nisha. Yeah. Would you be able to talk to valuation for a second?
Sure. Yeah, absolutely.
And I know it's different for psychiatry because it's basically, you know, good faith. We don't have any, you know, like devices.
Yeah, I mean, you should be looking at, the way we look at it, especially even within ophthalmology, there's not a lot of actual physical assets that here are worth buying. You know, there's patient charts if you want to evaluate that way. So I've done this from both the hospital side and the private equity side. Hospitals will tend to go in and purchase things based on patient charts or maybe some, you know, fair market value of assets. You know, if you're going and doing this with an aggregator, they should be looking at it from an EBITDA multiple perspective. So seeing, you know, how much your practice is generating, and then ideally, you know, any deferral is based on what your growth could be in the business.
Mm-hmm. Okay, thank you.
Yeah, no problem.
Really good.
All right. Well, I mean, we're just about at 1 o'clock, and so we want to be respectful of everyone's time. I thank you, everybody, for joining, number one. We're going to send out, and thank you, Gabby. I hope you got something out of it.
Yes, thank you. Thanks for the opportunity.
We're going to send out, you know, a questionnaire, but more so, it'd be great if you all could just email and just let us know, is this a good format? Do you have an issue that you'd like to talk about? Is there an area that's of interest to you? Do you have a, you know, something that we can focus on? And then we will we'll go from there. You know, we are starting to think about additional things that we're going to do over the next few months. And hopefully if this is a format that works, even if it's a small group, and it gives you some insight and helps you in your business, then I think that's a good thing. So thanks everyone, and we'll see you soon, I hope. Well, at least online.
Thank you, everyone.
Good luck.
Thank you very much.
Bye.
Bye.